Well, I think it's about time for respect to all of you that are connecting right now. And I think that we can start. So hello, everyone, and good afternoon here in Spain and in the rest of the countries in Europe, Middle East, Masal Khair, India and Africa, and good morning to those colleagues who are connected from the other side of the ocean. For those who don't know me, my name is Nasser Lasmar, and I'm Scientific Director at the Genomics Academy, part of Vitalife Group, here at iGenomics headquarters in Valencia, Spain. Before starting, I would like to remind you that you can see in our website www.igenomics.es/webinars our recordings, presentations, and you can register for future webinars. Today, my colleague and friend, Dr. Miguel Milan, who is the director of the prenatal department in iGenomics headquarters, will lecture about non-invasive POC, new non-invasive analysis of fetal DNA of miscarriage. This molecular study test of products of conception will help us to determine if a gestational loss was due to a chromosomal abnormality, making the analysis from the maternal blood sample. Dr. Miguel Milan will explain the importance of this test and how it can help healthcare professionals and patients taking informed decisions about managing their pregnancy. So, without further delay, I would like to introduce you Dr. Miguel Milan. Miguel, please, whenever you want, the floor is yours.
Hello, everybody, and thank you, Nasser, for this nice introduction. And for me, it's a pleasure to be here again, just explaining one of the, our new services in this reproductive / prenatal area. So let me share the screen, and please let me know if you can see the presentation.
Yes, just we need to place on the place on presentation mode.
No?
Not yet.
I think it's coming.
Yes.
Can you see the full screen?
Perfect. You can go ahead.
It's perfect? Okay, perfect. So, good morning and good afternoon to all the audience, and thank you for being here with us just to listen to this new launch, this new service that is called niPOC, as you can see in this first slide. And this new launch, this new service is, one of the services and one of the best examples of what our mission is, and is to bring new tools and new capabilities for doctors and patients just for the day-to-day support and the process making decision. So let's go with what is niPOC. So niPOC, as you can see in this slide, is an advanced non-invasive test in which we use is so simple. We use only a blood sample to determine in this blood if we can assess the cause of the miscarriage regarding the chromosomal abnormality. We only need, as I said, one blood sample. We analyze all 24 chromosomes for, to seek for aneuploidies, plus to seek for deletions or duplications greater than 7 megabases. Depending on the fetal fraction, depending on the sample features, we can detect some of these deletions and duplications. Sometimes we will have only information for aneuploidies. And it's important because, as far as I know right now, today, iGenomics is the only commercial or private laboratory offering this kind of service with scientific validation with our own casuistry. And this is quite important because perhaps in the future, because the amount of scientific literature that is, that you can find in PubMed or in other databases is growing, and probably different laboratories can start offering and can feel encouraged to launch services like this and to offer this service. But it's important for you as a customer to have a laboratory, to work with a laboratory that has a validation, a scientific validation, so you can have full information about the test performance for the test you are prescribing to your clients or to your patients. As a brief introduction, because I would like to explain what is niPOC, what is this non-invasive POC. with regard to what a miscarriage is. And all of you, I guess that in our audience today, or if some of them are watching this video, in streaming afterwards, uh, I think that everybody acknowledges that the miscarriage is not a rare event. So about 15%, depending on the series and depending on the setting and the population, but about more than 15% of all the pregnancies would end in a miscarriage, in an early pregnancy loss. In the general procedure, whenever you have a miscarriage, you know that, and this slide is only, don't pay attention on the percentage that you can see in this circle. This could vary from location to location and with your practice. But there is a percentage of cases in which what is going to happen is that accurate dates, dilatation accurate dates, is, the patient is going through these procedures, or in other cases, what is recommended is just to a medical procedure, pharmacological, giving misoprostol for an spontaneous and private evacuation of the fetal remains. When we are talking about the reasons why these miscarriages happen, this is one of the most frequent questions for the patients. Whenever you get pregnant and you suffer an early miscarriage, this is one of the most common questions. Doctor, what did this happen? And you know that today we know a lot of different factors, dozens of factors that can be the cause, the direct cost, or can contribute for the miscarriage to happen. And among all these different reasons that we already know, it's crystal clear that the most frequent is the aneuploidy. So it's quite clear that whenever you want to elucidate and to know if this miscarriage is caused by any reason, it makes a lot of sense, and it's been described in different articles in the scientific literature, that is the most efficient way to understand what is happening in this miscarriage is to start analyzing aneuploidies and to seek for genetic causes rather than other reasons like thrombophilia, infectious reasons, or endocrine reasons, immunological reasons, whatever. It's more efficient to start looking for genetics. And it's well understood that in the general population, about 50% of all the early pregnancy losses are due to aneuploidies, and these figures can be increased up to 60% in the IVF population. Okay. What is done whenever a patient suffers a spontaneous miscarriage? Is not recommended by any professional guideline to start doing any kind of testing unless the clinical or the patient history says otherwise. In this case, whenever you suffer a miscarriage, the likelihood of having another consecutive miscarriage is about the same. It's about 15, 16%. So this is one of the reasons why generally the professional guidelines, they don't recommend to perform or start doing testing, any kind of testing, genetic or not genetic, in the patients. The second reason is because this testing costs money. And the third reason that I think is quite interesting, and I think is one of the most important reasons why it's not recommended to start doing anything in the patients at the beginning with the first miscarriage, is because obviously today or yesterday, what we had to do is just to get the fetal material or the placental material, typically through DNC. There are other ways of sampling, but this is the most extended one. And once you get this fetal material, placental material, you have to do a genetic testing. And this genetic testing classically has not been very efficient. And about 50% or more of the cases, depending on the location in which you live, but about 50%, and this is what you find in the scientific literature, is not successful. So you don't have any genetic result. So the patient go through all the procedure, getting the sampling, getting the tissue, perform the genetic analysis, just to be non-informative and not to have any sort of result. So I think that altogether is the reason why it's not recommended to start testing in the patients unless it's a second consecutive miscarriage, and in this case, obviously, you have a problem, and they recommend to do something in the patient, to start studying this patient just to rule out what is the reason for these consecutive miscarriages. Okay. Once you get the material, in case it's a recurrent miscarriage patient, or in case you are interested in doing the genetic testing, what is classically applied in all the countries. And one of the reasons too is because it's included in many insurance companies, is the karyotyping, okay, to do a classical karyotyping. And this approach has several problems that you can see listed in this has benefits and problems. Some of them you can be listed in this slide. That this problem has been somehow passed or overcome with new approaches like the NGS or the chromosomal microarrays, in which you don't need the culture to grow. That is a requirement for the classical karyotyping and is a source of non-informative results or these failures to get a genetic result. You increase the amount of informativity up to 80% or more. In case you perform an hysterembrioscopy, it could be close to 100%, and the resolution could be even greater. And additionally, you perform typically STRs analysis to rule out maternal cell contamination. So whenever you have a result, you already know if the result comes from the mom or this result comes from the fetus, placental or fetus. So obviously, you have trusty information to counsel or give a reproductive counseling to your patient. But in this case, in these two cases, and this is the reality so far, you need the tissue. What is the problem? The problem is, as you can see in this slide, and this is a wonderful article that was released a few months ago, and as you can see highlighted in this paragraph, the problem is that it doesn't matter that you want to do an invasive sampling, DNC or whatever, spontaneous evacuation, and you get the tissue, or whatever, an hysterembrioscopy. It doesn't matter. Even in a setting in which you want to get all the samples for all the patients, it's been described that, and this is our experience and the experience of many different doctors, is that about 1/3 of the cases, it's impossible to get the fetal tissue. So you have a population, you have a gap in this system in which you have at least 1/3 of the population that cannot have access to genetic testing. Additionally, even if you have this tissue recovered, you get this tissue and you perform the analysis, there is a proportion of those patients, above all those patients in which you get the tissue by DNC, in which you are getting only maternal material. And when you perform the STRs analysis, you realize that it's maternal DNA and that you don't have any source of information for the fetus, and you don't have any source of information for the reproductive counseling. So obviously, a high percentage of people or the women in which it's impossible to get a genetic result. And when we talk with you and for the question, okay, would you like to have an alternative that you can see in this highlight, a tissue-independent technique in which for those cases in which you cannot get a result, a technique that can give you this kind of information or much of this information? And the answer always is yes, okay? So the molecular basis of this non-invasive POC or this tissue-independent technique for the aneuploidy assessment is something that you already know. Most of you, for sure, you already know the NIPT, the non-invasive prenatal testing. That is a technique that is used for the prenatal stage over week 10 of pregnancy, and this is used just to determine if an ongoing pregnancy is at risk of Down syndrome, Pato syndrome, for the Edward syndrome, sex chromosome syndromes, or for in some cases in extended panels, to deletions, duplications, and so on. So to different genetic anomalies, okay? And when we started working with this kind of samples in ongoing pregnancies, soon enough, we realized that in some cases, we get the sample, the blood sample on week 10, before the sonographic examination is performed in the week 11 or 12. And once the sonographic examination is performed, they realize that the pregnancy was arrested early in week 6, 7, 8, whatever, okay? And the reality is that we get in those cases that, officially this is an early miscarriage, we got a result many times, so often we detected an aneuploidy. And then we had the clue number 2 that was in ongoing pregnancies, and for sure most of you can identify what is this picture. And this picture corresponds to a vanishing twin syndrome. It's a case in which the For those that you don't know what a vanishing twin syndrome is, it's a twin pregnancy. So the pregnancy starts with two sacs, but very early in the pregnancy, one of the sacs arrests. So this is a demise. So officially, what we have in here is an early miscarriage, and it's well described in the abundant scientific literature that vanishing twin is a clear example of false positive in the NIPT. Okay, why? Because what we got in the bloodstream is the cell-free DNA from these cases, and this cell-free DNA is contaminating the results that we are analyzing in the NIPT for the ongoing one. So we are detecting this. So it's crystal clear, and it was crystal clear from 2014, 15, 16, that the early miscarriages could be analyzed by NIPT, but what was lacking or missing was the information regarding, okay, but how reliable is the information, or how frequent are you detecting those aneuploidies, and in how many cases are you missing? Because obviously those sacs are smaller than the ongoing one, and perhaps the amount of fetal fraction that you have in here, fetal fraction is the cell-free DNA from the placenta that is being released to the maternal bloodstream. Is this sufficient or not to make a calling for an aneuploidy? Okay, so for this question, we perform different approaches. First of all, I want to show this slide in which the amount of information and the experiences using the cell-free DNA in case of miscarriage is not super frequent, but you have just a bunch of articles describing this. Okay, the last of them is ours. That is this article in which we decided to to show or describe our experience using and analyzing the cell-free DNA in these cases of fetal miscarriages, in which you can see what is the accuracy, you can see the sensitivity and specificity for this kind of analysis. The procedure, you can imagine, if you know the NIPT, that is quite simple. It's just to take a blood sample, a blood draw. We receive this, we isolate the cell-free DNA that is floating. We have in our organism and in our blood, what we have is our blood cells, and that in the plasma, we have floating and free all the cell-free DNA from all our tissues and organs. And obviously, in a pregnant woman, what is started to happen is that the cell-free DNA from the placenta is being released. In the case of an early miscarriage, and whenever the fetal remains is still inside, that is not evacuated, we can find this cell-free DNA in the plasma, in the maternal plasma. And this DNA can be analyzed by our systems. And with bioinformatic algorithms, we can determine and assess if an aneuploidy is present in the maternal bloodstream. And so if this is the cause for the device, okay? The validation that we perform shortly, if you need more details about this, please be in touch, reach us out, just to understand better the analysis that we've performed. The validation is what you can see in here. So we started analyzing pregnancies from week 5 of pregnancy, okay? So demise from week 5 to 16. We included a number of cases in which you know that in iGenomics, we have a current service for invasive testing, in which we have the DNC, we get the fetal tissue for our POC service that I guess that you already know. This is the invasive one. And along with this fetal tissue or DNC tissue that we get, we ask for a maternal blood sample just to rule out with STRs if the analysis and the DNA that we isolate in this sampling comes from the fetus or placenta or comes from the mother, okay? Just to identify if there is any sort of maternal cell contamination. Taking advantage of this blood sample that we have, we can isolate in here, extract the plasma, the blood plasma. There we have the cell-free DNA floating in this case. We can perform our analysis following the NIPT procedures, and at the end, what we have is our proprietary and registered algorithms to perform this aneuploidy calling. And in short, what we get in this parallel comparison with the reference, that is the invasive POC, with the NIPT procedure, with this niPOC procedure, is an 88% of concordance, what is in line with the experience of all other groups and laboratories performing the same procedures and describing this in the scientific literature. So good numbers. Obviously, is 88, so this is not 99, like you can, if you know the NIPT, you can understand and you can remember that the specificity and sensitivity for this kind of testing ongoing pregnancies is around 99% for all the conditions that are tested. Obviously, in those cases, the sac is bigger. Obviously, in those cases, it's an ongoing pregnancy with more fetal fraction, and the amount of cases with a reliable result is greater. In these cases, we are analyzing pregnancies that are under week 10 of pregnancy with less fetal fraction, and obviously the concordance could be lower. Anyway, when we talk with you, and before, prior to launch this service, we were talking with many of you, with many gynecologists and obstetricians, just to ask if these figures are good enough to launch the service, and if these numbers, these figures are good enough for you for your genetic and reproductive counseling. And the answer always was yes. So it's important for you to know that this is the concordance rate, okay? Regarding the benefits of the test, obviously, this is the first one. The first one is that you don't need an office, you don't need a surgical procedure, it's non-invasive. So it's as easy as to get a blood draw and to send this to the laboratory. So no need to do DNC or hysterembryoscopy. There are some doctors that they don't want to do, or they don't know how to do. So, and the typical practice is just to give misoprostol for an spontaneous and private evacuation for the women at home. So these kind of techniques for these doctors that they don't want to go through an invasive sampling, it's perfect. It's non-invasive. Right away, you can take the sample and you can send this to the laboratory. And in other occasions, for example, what you have is a patient that she, psychologically is quite affected, and she wants or prefer to have this private evacuation. She doesn't want to go through this DNC and everything. So in case it's medically recommended that you want to do it, you can do that. And in case you are interested in knowing if the cause of this miscarriage is genetic, you can do the niPOC, okay? The second reason is that it's fast. So, in comparison, for example, with the karyotyping, in which you have to take this DNC and you have to send this for the culture to grow in order to get the metaphases and everything and all the results, that takes like 1 month. In this case, for example, is much faster because we receive the sample, we process the sample as we do for the NIPT with more or less the same TAT. It's about around 7 to 10 working days to get the result. So you can see the comparison is much, much faster, okay? Regarding who can benefit from these niPOC results, obviously, this is our opinion. This is something that we think it could be perfect in your setting, but it depends on your setting, on your clinical practice. But for us, make a lot of sense that if you are a doctor in which you are okay and your routine is just to get the fetal tissue, so this is the way to go. Why? Because it's the reference, because you are testing directly the fetal tissue or the placental tissue, so you are not doing any indirect analysis. And POC or an niPOC, the non-invasive POC, can be considered only as an alternative to rescue some cases of POC where the result is non-informative due to maternal cell contamination or whatever, okay? So in those cases, if you are happy and you are, familiar with getting the tissue and sending the tissue to be analyzed, so this is the way to go. And you can think in the niPOC and a rescue alternative. So with this message, what I mean is that the niPOC, when we don't want for you is just to think that the niPOC is an alternative and a substitution of the NGS or the CMA testing. Okay, so these are amazing testing whenever you get the tissue. And for those cases in which the misoprostol is the way to go because you decided to give this drug or this medical procedure for the patient and no tissue is going to be available, so this is quite important. The tissue is still inside, so the evacuation has not been produced, but you want to go through this way, misoprostol for this private evacuation. So in these cases, you have now, when yesterday you didn't have any alternative, now today you have the alternative of the non-invasive POC, and this would be the way to go. Okay, who is the niPOC test suitable for? So for any kind of miscarriage. So I want to be crystal clear here. If you pay attention to the professional guidelines, obviously it's crystal clear that the recommendation is for recurrent miscarriage. That means with 2 or 3 consecutive miscarriages, okay? So after 2 or 3 consecutive miscarriages, you can perform any sort of testing, genetic or not genetic testing, okay? But in this case, I think it's quite clear, and you can see in the scientific literature plenty of articles describing what is the benefit of the psychological benefit for this psychological distress that many women have after an early miscarriage. So above all, for those patients that go to your office, they have this miscarriage and they say, okay, doctor, I think it could be good for me, psychologically good for me, just to know if the reason for this miscarriage is abnormality or not, to find an abnormality and an aneuploidy or not, because I need this psychologically. Point number 1, I think this is very positive for the patient, and in case you are not planning in doing any DNC, niPOC could be an alternative. Point number 1. Point number 2, this kind of information, regardless is the first miscarriage or an isolated miscarriage, can give a good prognosis for the next pregnancy. Why? Because in case, it doesn't matter that it is an isolated miscarriage. If you find out that the reason for this miscarriage is an aneuploidy, these are good news. Why? Because everybody in the world is exposed to have miscarriages due to aneuploidies, because everybody in the gametes, everybody in the gonads, we have abnormal gametes, aneuploid gametes with mutations, with any sort of mutations, okay? And this is natural, and this is normal. And this means if we find out with an niPOC that this miscarriage is aneuploid, is a good prognosis for the patient at this moment, okay? Because the problem is not in the organism, in the female organism, it's a problem in the embryo. And the chances for this to happen again are very reduced, okay? The other way around could be different, because in case we don't find any genetic cause in the embryo, that means that perhaps the problem is not the embryo, the problem is the mom. And it's a good idea for you just to review the clinical history of this patient, just to think what you want to do in the next step, okay? Obviously, a suitable target population should be, for example, the assisted reproductive, the ART patients, okay, having a miscarriage, for 2 different reasons. The first is because one limitation of this niPOC, if you know what is the NIPT, and the technical basis is exactly the same, is that we cannot detect with the niPOC triploids. So if we cannot detect triploids, the triploids are or represents 5% of all the miscarriages, okay, of all the early pregnancy losses, 5%. But in the case of the IVF population, this, is reduced up to 1%, 1.5%. So this limitation is less limitation in the ART population, in those patients going through an assisted reproductive treatment. And additionally, the niPOC can serve as a new decision-making tool, as I can explain in the next slide. As you can see in this slide, this is the regular situation. And this is not the first time that I receive a call from a patient like this. So I'm an IVF patient. I went through all the procedure. Finally, I got pregnant, but I suffered a miscarriage. So I don't know why. So the first question is, why did this happen? Question number 1. And question number 2 is, okay, in some cases, those patients, they have embryos remaining, frozen embryos remaining, or doctors recommend to go to a new cycle, stimulation cycle, to start over again for a new transference, okay, for this reproductive success. But the reality is that when you have a cohort of embryos like this, and the only tool that you have is the morphokinetics or whatever, the morphology, you don't have a clue of what kind of embryos, which one is the aneuploid or the aneuploid that is most likely, producing a no pregnancy or a miscarriage, or even worse, a live birth with a congenital syndrome or whatever. Okay, so this is the reality, and the reality is that not all the patients are going through a PGTA or an embrace the need for the embryo selection. But the reality, and this is something that we already know, is that inside the cohort of embryos in an IVF patient, this is the reality. So we have a percentage of embryos that are normal and a percentage of embryos that could be abnormal, let's say this color. Okay, and based on the morphology, you don't know what to pick again. And perhaps in a normal patient without any sort of indication, it's okay just to select the embryos by morphology. But in a case of a patient in which, and this is just the example, it's a patient that is trying for a long time to get pregnant at home, so they have this psychological burden. Then they decide to go to an IVF center just to get pregnant. And then at this moment, they have psychologically, physically, because of the drug administration and all the hormone treatment and everything, economical burden because it's a super expensive procedure and pathway, and then they get pregnant and suddenly they have an early pregnancy loss. So you can see in here the psychological burden that they may have, okay? And what is the point? The point is that in here, you don't know the reason why this patient aborted, okay? Or suffered the miscarriage. And the procedure in many cases is just to try again. And which one is the embryo that you are going to select for this transference? When this patient, most of these patients, they don't want to miscarriage again. So we think that perhaps the niPOC in this setting could be beneficial because it's non-invasive, it's fast, it's clean, okay? You don't need a DNC. You don't need to get this tissue to perform the analysis. That if you can, it's okay. It's totally okay. But if you don't want or you think it's not recommended for this patient, perhaps the niPOC in this point and analyzing this isolated miscarriage or fetal remain can give you information regarding if no aneuploidy is detected. Obviously, there is no reason, no genetic reason for this miscarriage in the embryo. The embryo is not the problem, so you can review and check the clinical history and decide if you want to transfer something again. But in case you find in the niPOC, in the non-invasive POC, an anomaly, obviously the reason is the embryo. And I think it's not a good idea just to go to the cohort again and to pick one just in case this is normal. And I think that in this point, this is something that you should consider, that the niPOC can help you just to indicate PGTA or embrace for this patient. Obviously, the PGTA and embrace, they are not creating haploid embryos, but they are giving you an order regarding which embryos are those embryos which, the better reproductive power or success, and you order the transference this way, okay? Avoiding, in many cases, a new miscarriage again, okay? This is something that we can discuss later on. And secondly, and not only for isolated pregnancies, for regular IVF patients with no recurrent miscarriage problem, but in the recurrent miscarriage problem, I think that the niPOC can help you to have perspective, because now what is happening in many different clinics is that a recurrent miscarriage patient is considered to those patients in which what we have is 2 consecutive miscarriages or 3 consecutive miscarriages, but we are not doing anything in the first miscarriages. Miscarriage number 1 or even miscarriage number 2, we don't do any kind of testing. And only in miscarriage number 2 or 3, we are going to perform a testing, genetic or not genetic. Imagine that we start doing genetic testing. So you realize that in this case, this last miscarriage is normal. So no aneuploidy has been found, okay? So in this case, patient number 1 and patient number 2 are equivalent. They are exactly the same. Since there is a problem because this patient is miscarrying and the last one is normal, what is being recommended and discussed with the patient is the convenience of going through the ASRM workup. That means karyotyping for parents, that means thrombophilias, that means the structural uterine analysis, and so on and so forth. I mean, infection, many other testing just to find out what is happening in this girl or in this patient, okay? Same happens with patient 3 and 4. If you see nothing is known about previous miscarriages, and the only information that we have, no perspective, the only information is the last one, and patient 3 and 4, what they have is an abnormal miscarriage. And based only on this information, okay, makes sense that they have a problem. Obviously, makes sense that the last one is an aneuploid, and perhaps it's the good idea to discuss with patients going through a PGTA to select the best aneuploid embryos for transference for the success. But what happens when you have perspective? And the niPOC is a non-invasive, fast approach to get this kind of information in case it's difficult for you, for your setting, to get directly the invasive tissue or invasively the tissue. Okay, so look that patient number 1 and patient number 2 are not equivalent anymore, because in patient number 1, the first and the second miscarriage are normal. So make a lot of sense to this kind of patients to recommend to go to this ASRM workup for these thrombophilias and other physical and physiological tests to rule out if something is happening in this patient, but in the patient. If you pay attention on patient number 3, is not equivalent, is not similar to patient 4 anymore, because the first one is abnormal, likewise the second. Okay, so in this patient, the recommendation through PGTA make a lot of sense, because you have 2 abnormalities. It seems that this is the reason for the miscarriage, and selecting aneuploid embryos make a lot of sense to reduce the likelihood of having another miscarriage in the future. But look at patient number 2 and number 4. They are not equivalent as in the previous slide. They are equivalent now, number 2 and number 4. And we get 1 miscarriage aneuploid, 1 miscarriage that is non-aneuploid, or no aneuploid that has been found in the fetal remains. So we don't have a consistent reason for miscarriages. And when we can think, or we may think, and we need to gather more information regarding what is the proper management for this kind of patient, should be, are we sure that you are a recurrent miscarriage patient? Because perhaps this is serendipity, and this was an aneuploid in the first, and something happened acutely, point in time, that was not an anomaly, and perhaps you can try again and you don't have a miscarriage problem, because nothing is consistent in your miscarriages. And this is something that we can find out in the future. And I think that the niPOC is an easy and straightforward technique and approach that can help us to get this perspective that we don't have currently nowadays. Okay. Regarding the methodology, super simple. Is the patient has to have this blood sample in your center or in an extraction center. Yes, to collect this sample, ship this sample to Genomics in your region, or in the case of Spain, to Spain. We perform the analysis, the DNA analysis, and we issue the report in 7 to 10 working days, depending on your location. It's quite important, these 2 slides that I'm showing now, and it is, the information is about the test limitations. If you know the NIPT, if you know the PGTA, if you know the CMA, the chromosomal microarrays, all of them share the same limitations. Are the limitations that you can read in this slide. But the first one, that is a triploidy. So the niPOC cannot detect triploidy. So this is important for you just to know what kind of patient do you have in your office at the time of recommending or not the niPOC, okay? Additionally, this niPOC or the NIPT has another limitation, that is that we are performing the aneuploidy analysis in the maternal bloodstream, analyzing all together the cell-free DNA coming from all the tissues and organs from the mom and the new tissue that is now in the pregnancy, that is the placenta. So it's quite important to know that it's rare, very rare to happen, but in case we have a mom with an abnormal karyotype, this could cause a false positive. And this is important for you to know. So in case you have a patient in which you want to perform, you are willing to perform an niPOC, but you know that the patient has an abnormal karyotype, please talk with us prior to send us the sample. Who the test is not suitable for? Obviously, if the triploidy is a limitation, obviously to those cases in which you suspect that this miscarriage could be triploid or polyploid. This is the case, for example, of molar pregnancies, in histories of patients with, histories of previous miscarriages with polyploid, triploid, or tetraploid, miscarriages, or in cases in which, for example, you perform an sperm aneuploidy testing and you realize and you find out that you have, an increase of diploid sperms, and this is a risk for triploid pregnancies. So in those cases, for those specific patients, niPOC is not a good solution, and you should, if you want and you are willing to get a genetic testing for these fetal remains, you need to go invasively to get these fetal remains and perform CMA or NGS directly in these cases, and so on. Okay. Conditions that may impact the test performance, and this is important information. The first and most important, obviously, is the BMI. So in cases where the woman has a huge BMI, we already know by the NIPT test in ongoing pregnancies that those patients has more likelihood to have non-informative result because their own maternal cell-free DNA is diluting the fetal one. So it's exactly the same in the miscarriages. In the miscarriage, we have a proportion of fetal or placental cell-free DNA circulating in the maternal bloodstream. In case of BMA, this is diluting, and we are at risk, or this population has increased risk to have non-informative result. So I think that this is important information when you have to discuss with your patient the kind of testing that she is going through in the next steps, okay? And this is quite important too. It's quite important that this niPOC is performed only if the fetal remains are still in the woman and no evacuation has been performed, because the cell-free DNA is well known that after the delivery, after evacuation, the cell-free DNA is cleared from the maternal bloodstream minute by minute. And you know that in the early miscarriages, we have few amounts of cell-free DNA. So losing cell-free DNA is not a good thing in this kind of testing. So niPOC make a lot of sense for those patients in which you perform a sonographic examination, you confirm that you have the fetal remains inside, and you take the blood sample in this time. Okay, it's not worthy for those patients in which they had a spontaneous evacuation. They go to your office and they say, okay, this happened. And then you take the blood for the analysis. For those cases, be aware that most probably they are going to be non-informative, and the patient is going through all the process, to get a non-informative result. And finally, the conclusions you can read in this slide. In couples who have a miscarriage, it's very important to find out the reasons behind this. This is important because the main reason in a miscarriage is aneuploidy. And to know if the fetus is aneuploid or not, again, I'm repeating the same concept, but gives you an idea about the prognosis for the next attempt, for the next pregnancy, okay? The beauty is that we've been able to characterize and to, launch this new technical approach that is tissue independent and that allow testing, in many, many, many patients that have always been unable to do so, to have genetic testing, because no tissue, because non-informativity due to maternal cell contamination. And now we can rescue this result or have this result with a simple blood sample, okay? And I want to stress this again, because I know that some laboratories can start doing this now, but it's quite important to have this scientific validation, and for you to have and understand the test performance metrics of this kind of testing, because this has a direct impact in the proper genetic and reproductive counseling that we are giving to our patients. And that's all. Thank you very much for your attention, and I will be glad to answer any questions that you may have.
Thank you very much, Miguel. We already got some questions from the audience, but I would like to remind to all of you that you can make your questions in the box that actually said questions, and Miguel would probably be happy to answer them. So I think that, Miguel, we can start with the questions that we received from the audience. And first of all would be this one that says, where and when will be this test available? I don't know if you are aware about everything worldwide, but question would be, when and where will be this test available?
Yeah, so currently, that the test is offered only in Spain and in the Middle East countries, but soon enough, in questions of weeks, I hope, we are offering this service worldwide in different countries. Okay, so for sure we are going to launch this shortly in Latin America. We are launching this shortly in Canada, in whole Europe. So all countries from Europe can send us samples here to Spain, and we can perform the analysis, worldwide.
Thank you, Miguel. There's another question that says, what are the main reason of 88% of concordance? And also, if you are planning to make some improvements on the methodology to increase it.
Yeah, this is a very, very good question. So the reasons why the concordance is not higher than that, I think, is because two different issues. The first one is that we are testing at lower fetal fractions, and you know that the fetal fraction is quite important for the aneuploidy colon. The higher, and it's the same in NIPT, the higher the fetal fraction, more robust is the aneuploidy colon. Whenever we are testing with less fetal fraction, because the sacs are smaller at early gestational ages, we can have less fetal fraction, and in some cases, we can miss some colons, okay, for some conditions. So this is point number one. Point number two is a technical reason, and has to be with the with the nature of what we are analyzing. So we are performing the analysis in the bloodstream. What we have a mixture of different source of DNA. So from all the maternal organs and the placenta. And I say the placenta, not the fetus. Okay. So sometimes when you have an hysterembryoscopy, what you are doing is just to get fetal tissue. So in cases in which, and we know that this is happening in the biology, is the biology of the pregnancy. There are a percentage of cases in which you can have a placental or fetal placental discrepancy, because the information, the genetic information that the placenta and the genetic information in the fetus could be different. Okay, so we are paying attention only on the gold reference, and obviously we are getting information from the placenta. So in these cases, obviously we don't have a concordance. And another source of discordancy that is not bad, but is this what we have, is the cases in which obviously when you perform a DNC and you select some villi, for example, or some tissue, whatever, but if this corresponds to the placenta, what you get is a small proportion of the villi. This is not represented the whole placenta. Okay, so you are performing is exactly the same as in the PGTA. You know that one of the limitations of the PGTA, and this is why in the PGTA cases it's recommended to perform an amniocentesis or prenatal testing, is because there is a percentage of cases in which the biopsy that you perform is not representative of the whole embryo. This is exactly the same. We are using as a gold reference the POC, so the DNC, the curetage, plus the NGS or the microarray for a small piece of the placenta, versus the analysis that we perform in the bloodstream that correspond to all the cells in the placenta dying. So we guess that is more representative, the kind of analysis that we perform with the niPOC in some cases, than the one that we perform in the POC. But anyway, the reference that we selected for this comparison is the POC, the invasive one, and these cases are not concordant. So these are the three reasons why we got this 88% of concordance. And we are super glad because, obviously it's not the concordance that you got in the NIPT, but you can see that it's super high, 88 is super high, and is as high as the better accuracies that you can see in different laboratories doing exactly the same. So I think that many laboratories are about the same sensitivity, specificity, and accuracy for this detection. And obviously, the next steps that we are working on is just to improve this detection and this accuracy to be increased. I don't know, let's see. But these are projects that we are currently performing.
Thank you, Miguel. There's another question that is asking, I wonder why pursue a genomics non-invasive POC test as opposed to sending the blood sample to a lab like Sequenom LabCorp, who offer 24 chromosomes aneuploidy evaluation for their NIPT product. Is there a cost reduction for patients that pursue non-invasive POC and then PGTA with the lab? Where can we find the validation study? and thank you. I don't know, Miguel, if you are the right person to answer if there's a cost reduction for patients that pursue non-invasive POC and then PGTA with the lab. That probably is going to be related with the salespeople in each region. But also they're asking, where can we find the validation study?
Our validation study, do you mean?
I think so.
Study. Yeah, our validation, if this person refers to our validation study, our validation study, this is our internal data. So we have all our, our data and everything in our documentation here in iGenomics. What we have is the publication that has or contains most of the cases included in the validation study in this paper that we've published, and you can find this article in PubMed.
Thank you, Miguel. Another question is, can the use of heparin affect the test results?
We don't really know. We don't really know because heparin is one of the, these of controversial factors that could be impacting all the cell-free DNA analysis that you perform in the maternal bloodstream. Not only the niPOC, the NIPT, and other cell-free DNA analysis. Why? Why? Because it's been described in few articles that heparin could be, affecting the PCRs that we are doing in the laboratory, or can be increasing the maternal cell-free DNA, thus reducing the fetal fraction, and thus creating non-informative result. Okay, so this is one of the effects that has been attributed to the heparin. But in some other articles, some groups answer to these descriptions, to these experiences, saying that the heparin, with a control experiment, showing that the heparin itself is not causing any sort of problem. So it's the matter that some patients taking heparin, they have immunological disorders, and these immunological disorders are the ones that are causing these low fetal fraction and problems or interfering with the NIPT procedure and results, and thus with the niPOC. So since nothing is completely clear, I strongly recommend you that in case your patient is taking heparin, and if they suffer a miscarriage, obviously the heparin is rapidly cleared from the maternal bloodstream. This is the reason why they have to administrate daily the heparin to keep a certain level in the bloodstream. So it's as easy as to get the blood sample for the niPOC at the next day. In case what you have is a patient with an immunological disorder, I think it's quite important to talk with her and let her know it's the same like in the high BMI patients with high body mass index, that this is a special group in which you would expect higher amount of non-informative results. So exactly the same. If what you have is a patient that is taking heparin because she has an immunological disorder, I think it's a good idea just to discuss this with the patient and for her to know that, it's a special patient, and perhaps the likelihood of having a non-informative result is higher in this kind of groups of patients.
Thank you, Miguel. We do have only 5 minutes before the end, so I'm gonna go forward with the next question. I guess that you told us in your lecture, but there's a couple of questions, similar ones, that asking again about from which gestational week can the analysis be performed?
Our experience is that we can perform the analysis from week 5 onwards. So 5 weeks, I know that five weeks is too early. So this is when you start looking the sac in the sonography. But we included for some cases in which, because they come from IVF treatments, and you know that in this case, you know exactly when the conception and the pregnancy started. We included some cases of 5 weeks, 6 weeks of pregnancy, and the results are so far amazing. So this is something that we want to grow, this kind of group, and to give specific test performance metrics in the future for these patients. But this patient has been included with all the rest of patients with different weeks of pregnancy, the mice, I mean, and the results are quite good, are super good.
Okay, cool, perfect. Because this is a problem, when you would like to analyze the process of conception and the earlier week of gestation and that happened the miscarriage, it's harder for us to get a result. So that's perfect.
There's that's question. The reason. That's the reason, sorry to interrupt, because I think it's quite important to clarify this point in here, because for me, make a lot of sense. Precisely what you said is the earlier the gestational week in the demise, the higher the maternal cell contamination, because you are doing the curettage. The tissue is so small that can be confusing just to get the correct sample. And most of the cases, and when I say most, I think that is around 40% of the cases in week 5 of pregnancy, the result that you get from this invasive DNC plus NGS or CMA analysis is maternal cell contamination. So we guess that niPOC is going to be improving these cases, because obviously the percentage of non-informative or non-informativity that we have with the niPOC is around 10%, but obviously 10% is much better than 40%, and it's improving the current service.
Cool, perfect. 2 last questions. We have more, but I can tell that, Miguel, we will be able in the next week or couple of weeks to answer
Perfect.
all of them. And we have one that says, when the result is aneuploid, I understand that detected alteration is reported. Will you change the recommendation depending on the alteration? And if the answer is yes, genomics guide us in this regard?
We always try to guide you in this regard. So not all the alterations means exactly the same. So we can find, for example, free aneuploidies that could be de novo, most probably de novo, and no recommendation. This could be the likelihood of having a new event in here could be exactly the same. So reduced, where we can see terminal alteration, deletions and duplication that can give you a clue that perhaps there is a parental, one of the parents could be carrier of a chromosomal rearrangement, and the advice is completely different. So depending on the anomaly, perhaps the advice could be completely different. The good thing about iGenomics is that we are a laboratory that we are performing genetic analysis for POC from more than 10 years, and we have analyzed more than, I don't remember, 13,000 samples for POC physically with the fetal remains. So we have a huge experience with the type of anomalies that we are detecting and the kind of advice that we give to all our customers, and it's being the same with this niPOC.
Perfect, thank you, Miguel. Last but not least, does it mean that this new technology is a replacement for studies that are carried out in a curettage with regular POC?
No, absolutely no. I think that the way to go, and this is something that we can discuss, and I would love to discuss with any of you that you can reach me out and discuss this. It's not the same an early miscarriage in which you have the DNC and you perform the analysis, you can perform STRs analysis, and you can perform the NGS, for example. There you are going to get some information that is not feasible today with the niPOC, for example, triploids. So if you are happy doing the DNC and getting that result, and doing the POC analysis as we have right now with the NGS, perfect. In those cases in which you suspect, for example, that perhaps it's not an aneuploidy, but you think that could be a CMV, a small CMV, that is under the resolution of a karyotype or the PGT-A or NGS platform that we have, we can perform a CMA, and the CMA is the way to go. I mean, for example, imagine a DiGeorge syndrome, and that DiGeorge syndrome could be the cause of this miscarriage. This is not going to be detected by NGS, so you can perform a CMA. And this is not going to be detected by the niPOC. Okay, so for me, make a lot of sense that whenever you can get the tissue, go for the tissue and go for the NGS or the CMA, depending on the gestational age, the quality of the tissue that you have, is fetal or not, etc. Okay. But for those cases in which you cannot get the tissue because you don't know or you don't want to go to the surgery room to get the tissue, you rather give the pill for the patient because she wants to have a private evacuation. All these circumstances, all these cases in which you are not getting the tissue, not at all. So for this is a group of patients that remain untested so far, then now you have an opportunity to offer the niPOC. Okay? So I think that this is not a substitution. This is a new alternative for those patients that remain untested before.
Thank you very much, Miguel. As always, really a brilliant lecture, super clear. And just I want to ask you for your last half minute or 1 minute telling us what would be the take-home message for all of us that we are seeing this new technology, new test, as you mentioned it, everything in not only in reproductive medicine, but in medicine in general is going through non-invasiveness. What would be the take-home message for all of us?
Well, I think that this is an important advance, an important service that is covering a gap, an important gap for patients that were untested. This is what just I said. I think that the fact that it's non-invasive is so simple and you know, direct analysis allows you, for those patients that you don't ever consider to do that, or for those patients that, oh doctor, I want to know that, but you weren't thinking about doing any kind of analysis. This allows you to do that in the general obstetric population, and it's quite straightforward and it's so simple. You can even think in you know, implementing or doing this kind of analysis in your IVF setting for those patients in which, you know, they are going through this painful pathway of, you know, psychologically distress and economically, you know, distress and burden, and then they get this early pregnancy loss. And then this niPOC can be a new tool for your management or for your decision-making process, just to decide if you want to transfer a new embryo again, or if you want to derive or indicate the PGTA for these pregnancies, just to reduce what, you know, what the patient, she doesn't want. She doesn't want a new miscarriage. So for me, make a lot of sense just to find out if the reason is an aneuploid embryo with the niPOC, and then to perform a PGTA, obviously, to select, you know, those embryos with the higher chances to be a successful pregnancy, and obviously with the lowest chances to have an aneuploidy that cause a miscarriage again. So I think that these are the most important take-home messages. Non-invasiveness, straightforward, the accuracy is so high, and I think it would become a fantastic tool in the IVF setting.
So thank you very much again, Miguel, for the wonderful lecture. And thank you all for being here today with us, and hopefully see you in the next series of webinars. Have a great day and a great week. Bye-bye. Thank you.
Bye-bye. Thank you.